So I'm now going to just briefly tell you what the agenda is for today, and then we'll get started. So in two main parts, we've got in a moment Peter, who's here in the room with me, will be describing some of the background and history of the development of the Somerset individual PPGs, and there weren't many at the beginning, to a network of PPGs, which is perhaps the most powerful strategic thing about the PPGs here in Somerset. We'll have a short break for questions and answers, any clarification for a few minutes, and then my other presenter here in the room with me, Sandra, will be looking more at the practicalities and the benefits and challenges, and then we'll have a good chunk of time, probably 20 minutes or so, for questions and answers if people have got those as well. So in a moment I'm going to pass over to our presenters, and I haven't forgotten to mention Christine Lincoln, who's also in the room with me here, who will join in the Q&A, particularly the A, I expect, because actually Christine has been in right from the start of the development of PPGs in Somerset, PCT and CCG. So I will just ask them to say hello before we move on to start today's presentation. So firstly I'm going to ask Sandra and then Christine, and then pass over to Peter to actually start the presentation.
Hello everyone. Yes, this is Sandra Wilson, and I'm speaking from the room in Taunton with Martin and Peter and Christine. I'm the chair of the Exmoor patient group, which is for the Exmoor Medical Centre, which is based in Dulverton. The practice has almost 4,000 patients, which covers much of the rural and isolated area of Exmoor with 3 GPs.
Hello, I'm Christine Lincoln. I'm the Patient Public Experience and Engagement Coordinator at Somerset Clinical Commissioning Group based in Yeovil.
Hello, and it's a good afternoon from me, Peter Rowe, and I'm the chair of the Somerset PPG Chair Network. And up until recently, I was also chair of my local practice in West Somerset, again, a very rural practice covering about 10,000 patients. Can I start by, first of all, thanking you all for signing up and listening to the way in which Somerset has embraced patient participation. My thanks also to Martin from the Patient Voice South project for setting this up. Learning from each other really is important, as is sharing good practice with each other. Outside of the main presentation, we put together a small number of slides giving examples of some of the things we have done and which you might find helpful. And we'll say a little bit more about this towards the end of the webinar itself. Today, however, is, in the short time that we've got available, an opportunity of, if you like, showing the skeleton of the things that we've been doing, or, in other words, to give a very brief overview of what has been happening effectively over about the last 4 years. Sandra and I are now going to take you through some slides, but just before we do, a quick word of reassurance, and I hope this is not death by slides, in that we won't be reading every single line of every slide, but picking out what for us have been some of the key points. However, if you want to ask questions on any aspect of the slides, then please do so. It really is important to us that you get what you want out of the session, so there'll be opportunities for asking lots of questions. For us, the important bit about today is that it is about the patient or lay perception of what we have done and what we have achieved. So here we go. Our story relates to PPGs, but also to the strong county network of chairs. PPGs have been around for some time in Somerset, with the early ones dating back to 2004. The first slide that you're looking at the moment just very simply shows Somerset within the southwest, with, again, the little yellow triangles denoting where the acute hospitals are in relation to each other. slide is going to show us a little bit more detail about the county itself. From a population point of view, we are just over half a million people. Little notes underneath that are quite important to us because one of the key challenges facing the county is to deal with a significantly ageing and dementia population. The current figures on their own represent about 12% of the population. The scary statistic is the growth that Somerset is experiencing in the ageing and dementia, in that in 20 years, this figure is forecast to grow to in excess of 20% of the population. Working within the county, we're very rural, as I mentioned earlier, with significant areas of deprivation in both the rural and of the urban areas. And it also follows that, showing how rural the nature is of Somerset, in that only 1 in 4 people actually live in the 3 largest towns. The other thing which is worthy of note within the county is that we don't have the best of transport links, and the business of getting from one side to the county can be fairly lengthy and quite tortuous at times. Our patients are looked after by 75 GP practices, but one of, I think, really good things so far as Somerset is concerned is that we have a large number of 13 community hospitals, which is quite high, I think, compared to other areas. It's worthy of note that over many years, the communities themselves have fought hard to retain their local hospital, and one of the long-term benefits of that work is contributing to the goal of treating patients as close to their homes as is possible, and currently in line with what the government thinks, although we know what they think changes from day to day. From a PPG perspective, in the way in which our practices are supported, we've an excellent record of 67, and the numerate amongst you will see that the numbers don't add up in that bottom box compared to the number of GP practices, and this is simply because in 2 parts of the county there are 2 practices that share the same premises and have a single PPG. A very quick word on virtual groups. From our point of view, a virtual group is an online group that's been established within a practice for patients who would like to be involved, like to receive information and questionnaires, but have no wish to attend meetings. I think it's also fair to say that some practices may prefer that as a means of having their own, what they would call, patient group. Moving on, I want to say something about the early development of PPGs in Somerset. The early development was driven by a lady called Margaret Grisell, who at that time was the Patient, Public and Career Involvement Manager of Somerset CCG. As you can see when you heard from Christine earlier, we don't really believe in short job titles. The network, though, is hugely indebted to the work that she undertook. And I say this because it is really important that there is a champion within the CCG for patient participation and driving that agenda forward. Until her recent retirement, Margaret was the advisor to our network, and we're now looking forward to working with her successor. This slide simply shows the effect of Margaret's work. I'll just say something very quickly about the bars because the screens in some areas are probably quite small and it may be difficult to see it. But put very simply, the blue bars at the bottom relate to the growth of the PPGs that are actually in place. The red bars denote the planning of PPGs in the areas, and from August 2012 only saw the formation of the early virtual groups, and the green bars at the top simply show where the progress of where there haven't been PPGs. Moving on, I want to say something now about the history of the network and its formation. This really, from our point of view, was both an important and very significant development. As the saying goes, from little acorns grow. When I look back, the growth from the early days has really been quite phenomenal. Our chair network has a typical attendance of about 40, and the meetings are both lively and stimulating. One of our key challenges has become to try to get through lengthy agendas, and as a consequence, we've just moved to 5 meetings a year, and 2 of these are all-day affairs. The attendance of the chair of the clinical commissioning group and some of the directors is an important aspect of us working together to benefit the patient. The interface is very much a two-way interface and is welcomed and embraced by both parties. Something briefly about our own network here, in that in chairing this network we have an amazing array of talent, of people who give of their time in pursuit of getting the best for the patient and trying to ensure that the patient is at the centre of what is happening. I've already mentioned the difficulties of transport, but I do believe that the quality and the value of our meetings is such that PPG chairs are prepared to travel across the county for meetings. As an example, Frome to Taunton is at least a 2.5-hour trip, and I think nowadays people only like to attend meetings when they believe they get something out of them, particularly when they're doing that on a voluntary basis. And a key message from me, if you like, at this particular point is that there's a huge array of talent and ability within the patient networks. So please, please use it. Moving on, I want to say something about the value of the network. And I just want to focus on a few issues in particular. Awareness, which is a very important topic, in terms of what is going on both nationally and locally, has improved dramatically through the work of the network. This is evidenced through the quality of the contributions that are made at our various meetings and the improvement in the knowledge base of PPGs. And the more we can build the understanding of patients and people connected with patients about the issues being faced locally and nationally, the easier life, hopefully, will then become. One of the other upside, I think, is that because of, if you like, the array of talent we've got and the way that we've demonstrated that, this in turn has led us to be asked to become members of all sorts of other groups relating to the health service, and more on this a little bit later on from Sandra. Our contributions have meant that we've also become a key consultee with the CCG and with a number of other key health organisations. The final point, which I also regard as one of our major successes, was to persuade the CCG that we should have a lay observer seat on both the CCG and the COG. For us, I know it's not in every area, it's for the Clinical Operations Group. This group sits under the CCG and is the engine room of the CCG, where the detailed and complex work of service planning is considered. The county itself is divided into 9 GP federation areas based geographically, and every practice is a member of a federation. A delegate from each of the 9 federations also sits on the COG, which in turn is also supported by a management team. And in terms of what I said earlier about working in partnership and the closeness of the relationship that we have had with the CCG, the final point I want to say is how much I and my colleague, Chris Simpson, who sits as the lay observer on the COG, have appreciated the way that we have both been welcomed and embraced effectively as full members of each group. We can honestly say that we feel we are part of an effective partnership, and that means an awful lot to me and I know to Chris. And I think perhaps this is the time for me to pause and bring to an end the first part of the presentation, and I'll now hand back, if I may, to Martin, please.
Okay. Thank you very much, Peter. Just a short break, really, for a question or two or a comment. We've got one coming up there. I'll just wait to see if anybody else wants to type a comment or raise their hand to ask one by phone. Should we deal with the question which has come up in the chat box there, which I hope you will see? Keith Harrison is saying, what's the annual budget? I don't know whether Christine's looking as if she's working it out in her head, but what's the annual budget to run the network and how is it allocated, and recognising the travel costs for yourselves? Can you make some comments on the funding then?
I'll make a brief point, if I can, in that we're not actually allocated a particular budget, but within the CCG itself, there is a specialist patient and
patient budget that pays them travel expenses for chairs that attend meetings.
So I'm not sure whether you heard that, because Christine's a little further away from the microphone than I am. But there is a budget which pays for the travel expenses for chairs who attend all of the meetings, and we are supported by Christine, who is our key administrator and does all the work in relation to the calling of meetings, etc. And there is a small team within the CCG itself whose work relates to the public participation issues, but I can't tell you exactly how much that budget is because I'm not a budget controller of it.
Well, thank you, Peter. I think that the gist of it is, perhaps to summarise, is that the chairs who attend the chair network meetings supported financially for their travel costs. Christine is a CCG employee, long-standing CCG employee, so there's a resource, if you like to call it that, there as well. Is that full-time, Christine, would you say, or on PPG network work, or a day a week? Or?
It's probably about a day a week, 2 days a week, plus all the meetings that I attend.
And actually attending the meetings as well. So, yeah, so there's a serious investment there by the CCG. The individual PPGs are funded in the normal way that they are in any practice by as we know, the changing allowance in their payment. So, Peter.
Can I just say something about PPGs and practices? Practices, to the best of my knowledge, don't pay their volunteers to attend the meetings, and predominantly I think they're a lot closer for people to attend because it's their local practice. But again, practice varies significantly across the county in that my own practice is supported at every meeting by the practice manager, and there's always a senior GP partner who attends every meeting, but it is chaired independently, whereas in other areas you can find that different practice pervades.
Okay, thank you. And we've got another question there from Joe. Joe, I hope you don't mind, but I'll actually I will take it as a question, but after the next bit of the presentation, because there might be some answers to your question, which is how is Healthwatch Somerset, and I guess that's the question, whichever part of the country you're listening in from, how they involved in the network, and because if we open that question up later on, we might get some useful facts from some of the others of you in the seminar today about how those relationships are within your area. So rather than just say what the Somerset relationship is, we'd be interested to hear from others. So I'll hold that question, if you don't mind, Joe, and we'll bring it up in the main questions and answers later on. So I'm now going to pass over to Sandra, who's going to complete the second part of the presentation.
Hello again, everyone. Yes, I'd like to start off by talking about some of the values that are seen to be to the practices of the PPGs. Primarily, one size does not fit all. That has to be said at the outset. But I think in principle, PPGs set out to be a critical friend to practices and to consider the experience of patients at their surgeries. Inevitably, PPJ members come with a various backgrounds of a skills base, which contribute to the makeup of a PPG and add value to that in itself. One of the activities that patient groups can get involved in is helping with the setting up and running of health promotion events. For example, healthy eating, men's health, women's health, etc. Most patient groups seem to be involved these days with the running of flu vaccination days. Some practices have vaccination clinics outside of the practice. Others just run them from the clinic days within the practice. But most patient groups seem to be involved with the helping the through flow of those clinics. And another involvement can be help with surveys that practices in some areas have statutory surveys which need completing, and from time to time either the practice or the patient groups themselves would like the views of patients on in specific services, etc. And patient groups get involved with being in the practice, in the waiting rooms, encouraging patients to complete surveys, etc. We get involved with the helping of this and setting up of specialist groups, and depending on specific circumstances of particular groups and the size of groups within a practice. This may be, for instance, Parkinson's, diabetes, and carer support, etc. And we also, using the skills base of the patient group, can help with, at times, around new buildings projects when new health centres are being considered. Obviously, with new requirements that weren't around in the days of the building that the practice might be moving out of. So particular skills relating to the architecture, the construction, and the practical use of the building can be obtained and given input from members of patient groups. Help with the content and design of a website is something else that I know individual members of patient groups can contribute. And as mentioned earlier, the ad hoc surveys in waiting rooms, etc. Some patient groups I know even get involved in interviews for practice staff, if there's anyone with any particular skills in that direction. Some of the successes that patient groups have experienced, as Peter's referred to, is a relationship with the clinical commissioning group. We have the observers' representation on governing bodies, on the governing body of the CCG and the COG, and, for example, also help and have involved in consultations with mental health strategy, on mental health strategy, Somerset CCG strategy, and membership on key working groups such as the NHS 111 and out of hours procurement, which is a big one for us at this particular time, local implementation groups, etc., as you can see listed there on the slide. Some of the subgroups that we have been involved in and set up, Peter again referred to the virtual online patient group, and we set up a subgroup which looked into how to go about setting up a virtual group, produced a paper and distributed this amongst the GP practices across Somerset. We had another subgroup which was set up to write the Constitution, and I believe both of these documents you may find are distributed to you after the seminar. Using one of our development days, as you will see there, we have a stop press, which has is about the fact that the Somerset PPG are about to embark on work with the preferred bidder of our out of hours and 111 organisation, and we're going to be using one of our development days to discuss with the preferred bidder on how the patient's voice will be heard and how we will be involved with the organisation ongoing. Inevitably, there are challenges and frustrations in any organisation, and patient participation groups are no exception. As you'll see, we sometimes feel as though it's a tick box exercise, and we are being paid lip service to. Again, I think that may not be peculiar to patient groups, but we sometimes experience that practices may feel threatened, and one of the areas that we think this may have come out of is that sometimes because we meet, because groups want to come and talk to us as a network that Peter's talked about, we may even find that we're hearing news and receiving information before practice staff hear this. And in fact, that's actually an advantage, because we're able to cascade that back to the practice, to the staff and to the other PPG members, and hence the patients, more quickly than it might otherwise have been achieved. Recruitment, another biggie. Of course, this involves time, and that's something everybody is always short of, particularly when the practice may be in a rural area or have particular short demands, shall we say. Looking at the time, the place that the meetings are held, and what sort of involvement is expected can help with, in clarifying that, can help with recruitment, so that people understand right at the outset what they're actually committing to. I have to say, in my own case, that I have a wonderful team of members who have all come forward. We haven't actually had to go out and drag people off the street, but we hope to enhance that vastly by the growth of our virtual group as well. I think that really is all I want to say on the grassroots of patient groups at a practice level, and I'll now hand you back to the chair to give an opportunity for some questions and answers, if there's any questions from you.
Right, thank you very much, Sandra. I believe there are some questions typed in the chat box, and just a little reminder that as a group of equals, as we are sitting around our PCs, please also feel free not just to ask a question of my three guests in the room here, but to exchange ideas amongst yourselves and to reply to them as well. So some of the questions here which are coming up in the chat box, which I think you can see, I will pose those to the panel here, to Sandra, Christine and Peter, but also it'd be great if you wanted to make your own replies, sent to everybody about what's happening in your local area, whether that's the CCG, which some of you are obviously from, or one of the other organisations which clearly would be area-based. So we've got about 4 questions, and not forgetting the one about Health Watch, which came up a little earlier on. So those are 4 or 5 questions in the chat box, but if now or at any time any of you would like to ask a question by phone, and turn that into a discussion if you like, then please just use the icon to raise your hand, which I think we've understood how to use now. So in order of the questions as they've come up, we've talked about budget, but there's a question here from Liz Cosford, and if she wishes to, Liz, you can ask the question, but I'll do it for you if you like. And that question is, what about the 8 practices that are not involved? Is that just, well, they'll come along anyway eventually, or has there been any particularly active work that's been done to engage or encourage those to actually have a PPG. That's not about being a member of the network, it's just to have one at all, isn't it? Would either of you, any of you like to comment?
I'll comment briefly, if I may, in that I think you actually have to work quite hard with practices because you've got to persuade them that the formation of a PPG is for the good of the practice and for the good of the patient. You've got to get them to the position where they want to. At a personal level, I've worked quite hard with the chair of the CCG in using his influence when he is around and about within the federations of that active encouragement. And I think that has borne fruit in that we've got to the position that we have today, where we've got only about 2 or 3 practices who have no involvement on a formal basis with patients at all. It's about trying to demonstrate to people that actually it is worthwhile and you can show them what some of the benefits are. And I think that has proved to be the case in the past, and we've had various members of the county network have actually gone to 1 or 2 practices in the past to talk to them about what a patient network is about. There is nothing for the practice to be afraid of. It's not going to be about the PPG trying to run the practice. And we've tried to support practices in terms of how they've actually operated successfully in other parts of the county. But at the end of the day, you can lead a horse to water, as they say, but...
Okay, thank you. As I say, please do keep... there's lots of questions. I hope we'll have time to deal with most of them, but do exchange views or experiences as well in the chat box to each other, which I won't pick up, but you'll be able to read. There's a question here also, which I know we touched on and has come up before in other conversations I've had, is about the original function of a PPG to work at practice level. And maybe we could just hear a few more, or an example of, in Somerset, how the network has been able to influence and shape CCG commissioning. So in other words, that move from local to actually, can you give us an example of somewhere where you've been involved in CCG commissioning?
Yeah, there's two or three examples, and whilst I'm just saying a few words, I'll get Sandra to think about perhaps 1 or 2 others as well that she can bring in. But there are 2 key things that come to my mind. One is the commissioning exercise that's just taken place in terms of the one-on-one and the out-of-hour service, where we've had a member right in the heart of what has been going on, and we've been very extensively consulted at all stages in the process. And we like to think that the preferred bidder is actually going to bring a very different style of service that is felt to meet the needs of Somerset patients. Secondly, we do work very, very closely with the CCG itself, and the chair and the chief executive, together with other directors, come to between 2 and 3 meetings a year. And for example, last year we had a meeting which was a workshop type meeting where the CCG were actually posing a question to PPG chairs, fundamentally along the lines of, what do you see as the 5 key priorities that the CCG ought to be addressing within the coming year? Now, they never actually necessarily agreed or disagreed with what came out of that sort of workshop group. But what was quite interesting was that when we came back to the following meeting, when they actually presented their forward strategy and their 3-year plan, that all of the 5 issues that had been raised within the CCG were actually within that document in some shape or form or another.
Yeah, and I'd look at it and answer the question a little bit more globally, in that you're quite right. Patient participation groups have and do to work at practice level. That is the nature of the beast and the purpose of the beast. However, by having the network of chairs, this has enabled us to have a county and CCG level voice, bringing the grassroots patient voice from the practice to the CCG. And the very fact that the network existed meant that we were able to have some participate in the formation and the the shadow board, input to the shadow board of the CCG for a couple of years before it was became a formal organisation. So the very fact that we had the network, the network existed, was key to the fact that we are now able to influence and shape the activities of the CCG and have representation on it.
Thank you, Sandra. And thank you also to some of you who are typing the chat box with some responses, Q&As of your own between yourselves. That's great. This is one of those seminars where it's really good if you pass notes to each other when you were sitting in the audience rather than just come through us. So thank you for that, Keith and others. I want to come back to the question. We have several questions really about other people, or rather other organisations, and how the network fits in with those. So we've just spoken about how the network is influential within its CCG. And there's a question here also about Healthwatch Somerset, and again, people from different areas might like to comment on that themselves. But Peter, what's the involvement of Healthwatch Somerset? Could it be different? Is it be as discreet or as frank as you wish?
Oh dear. Perhaps my voice says it all there. Healthwatch, in my view, has had a fairly checkered history. When I first became involved in the very early days with PCT, we had an organisation that was called Link, which worked very, very effectively with the old PPG network, if you like. With the change to the CCG, we had Healthwatch coming on the scene, and I have to be honest to say that the PPG network have been singularly unimpressed, particularly in terms of their first year of operation, that we notice very little difference. They're not a member of the network because it's a chair network, but they regularly they are regularly invited to attend our meetings. They're asked if they want to place any items on the agenda, and from time to time we actually ask them if they would come to our meetings to bring us up to speed in terms of what is happening. But if you ask me what one of the weaknesses is, I do believe at the moment that Healthwatch have still got some way to go to becoming an integral part of the manner and the way in which NHS runs in Somerset. But I don't know whether Sandra has a different view. I
don't. I'm afraid we really have not felt as though we've ever really got a partnership with Healthwatch Somerset. We were involved in the launch of Healthwatch Somerset, and many of us attended that, but we really haven't had a lot of communication, and I don't think we can really enlighten you any more than that.
Okay, thank you. And it will vary from place to place, and it might reflect both the maturity, and that's just a measure of age, I'm saying, in terms of the network in Somerset and the newcomer on the block, as Healthwatch always is, since it's only started recently. There are a number of questions which are, again, about the way that the network interacts or is involved with other players in the field, if you like. And I hope I've got them all, but I'll add if I find them if I don't. But there's a question about how you might interact or do with any hospital, and we know you've got two, is it? Acute hospitals? Two acute hospitals, yeah. How you interact with any of their patient representatives or patient groups that they might have. And also a question, more of a strategic one in a way, is around your area team, which covers Devon, Cornwall, and used to cover Bristol, Somerset, North Somerset, and Gloucestershire, but of course that will be changing. But in terms of, have you had any done any work with the area teams and also with patient groups in the hospitals?
I don't know whether Christine in a minute can say something possibly about the area teams. My knowledge, I have to be honest, is not that great. In terms of working with hospitals, the county network per se doesn't interact with that sort of patient area involvement. But what we do have in Somerset is across the county, there's an organisation called the Health Forums. They're geographically based. We have how many?
9.
Forums? Yeah, we have 9 health forums which match the federation areas. And the constitution of those forums is deliberately quite loose, but it actually allows PPG chairs to go along. We have League of Friends coming along. We've usually got the hospital matron of the community hospitals. We've often got a foundation governor from one of the acute trusts. So there's quite an eclectic mix of people. GPs, the local GPs in the area quite often attend the meeting. Am I missing some, Sandra?
The district council are members. The education is represented. So yes, it's quite well represented of users of the health service.
And just to pick up the first point that was raised, I've just been whispering, I hope I didn't whisper too loudly to Christine, that we can't help you at this stage on area teams, but certainly the area teams, and the bit that I do know about it, don't as such interact with the county network or individual PPGs.
Right, thank you. And I'm almost certainly there's people in the seminar from Devon and Cornwall and or from the Patients Association who are actually doing some work funded by the area team to develop PPGs. So it's clearly varied throughout the south of England, the support and involvement of area teams. Can I, and they may, one of those would like to comment, some of those people from Devon, Cornwall or the Patients Association. Can I just move us on to a little bit back towards the individual PPGs? And we've had some questions around, I suppose, how they work and their representation. So there's a question here about other examples of young people being involved. There's a question around diversity. And again, clearly you're not accountable for this, Peter and Sandra, but you might have some examples within Somerset of where PPGs have worked hard at getting a diverse population represented. And then there's another question, again, all in the same theme, of how do PPGs get a person who they call their representative to represent every patient?
Okay. If I can pick up on that. It is difficult, and I don't think any one PPG probably is able to have representation for their complete patient spread. Again, given the demands of being on a patient group, and each area and each practice will have its own difficulties. It is obviously very difficult to, for instance, have ethnic minority representation when there isn't an ethnic minority in the practice area, but it's still on the list of requirements to cover. So that is one particular difficulty that we may have to be addressed and justified, I have to say as well. Having said that, we look at the geography that we're covering, the age group that we're covering, the maybe specialist health conditions that we're covering within membership, with particular concern, I suppose, for disabilities, various disabilities, etc. And I think, again, it depends on how many in number that an individual group can encourage to join. But with the expansion of virtual groups, the online groups, this should now become an awful lot easier. And I have to say, practices seem to be very supportive of helping with the expansion of virtual groups by distributing information and contact details for patients to get in touch to register as a virtual member, so that when questions and surveys need to be sent out, they can be contacted, and this could be the entire population of the patients, but that's unlikely, because it's unlikely that every patient is going to have an email address and be online. But certainly it's not unreasonable that up to 50% of patients at a practice could be contactable in that way, and that possibly 50% at least would be prepared to be a member of the virtual group. So I think technology is going to be of extreme value in this connection today and in the future.
Thank you. Anything from you, Peter, or should we move on to another question area?
No, the only point I would make is about PPG representative of all the patients. I don't see ourselves as being representatives of patients, but we, if you like, present a patient view. And I think the work you need to do is in the waiting rooms, in talking to patients. We do a lot of that when we do the flu jab day. This year we had something like 1,400 questionnaires coming back from patients. And when you're getting patients, when you're talking to them on the day, and sometimes the odd one complains about the practice and what they can do about it, then my standard response is, why don't you join the patient group? And it's sort of working hard on that effect. In my own practice, we have a regular newsletter that goes out to patients. It goes out via the practice itself on the notice board. It's a very, very well-read document, and we're constantly looking at ways and means of trying to enhance and broaden the representation. But we're not, quote, an elected representative. We're somebody who's actually decided to put their hand up and to volunteer for the task. And our problem is the same as what Sandra said, is to try for your open meetings, is to try to get the age, the gender, the ethnic mix that you really need to reflect your population. Because sadly, if I look at my own practice, the age range is probably 55 plus.
Right, thank you. Sandra just wanted to...
Yeah, coming back, I see there's a particular reference to young people and students' representations on PPGs. This is a bit of a difficult one in the sense that there may be concerns about confidentiality, etc., actually having a young person, by which I mean probably 16 or under, maybe 18 or under, actually sitting on a patient group. How this has been tackled and addressed by some is by having maybe a youth leader, or in some cases there are youth councils in areas, and their leader may actually sit as a representative on the group to bring their views to the group and take back thoughts and questions to them to feedback. So, yeah, it is a bit of a difficult one, and having a young person directly sitting in a group may not always be possible, but we do try other ways of encouraging information and their views to be brought to the group.
Right, thank you, Sandra. We've got what's great, thank you, everybody, is exchanging information. Not all of those things in the chat box are questions. They're useful exchange of views and experience as well. We've got time for probably one more question or question area. If anybody wants to, I'm going to say be brave because it's only a phone call, but ACQC. Yeah, I was just going to come to that, Peter. Yes, if nobody wants to pick up the phone, but if they do, please raise the hand, and we'll give you a few moments to do that and have a live question. If not, I want to pick up on just one of the areas which is still unanswered, which is about the involvement of PPGs or the network in CQC. So I'll just see if anybody wants to put that. Thank you, Carol. I'm going to unmute you now. This is Carol Munt. If you wouldn't mind, this might be a different topic, mind you. Wouldn't mind introducing yourself in a second, and you're live to the rest of the seminar, Carol. Hello.
Hi, my name's Carol Munt. I'm a patient partner at the Royal Berkshire Hospital in Reading, and I'm also on the Patient Experience Strategy Group at NHS Thames Valley. A couple of things come to mind. The last subject we were discussing was patient confidentiality and young people, and my only comment to that is surely everybody is patient confidentiality applies to everyone, and more to the point, patient participation groups should not be discussing individual patients. So if there's somebody in the room that has a particular issue that they want to discuss, as a chair of South Reading Patient Voice, my comment was we don't discuss individual patients in public, and that's something that I think should be taken on board. The other thing is that Health Watch, there was a comment about Health Watch, some of them are good, some of them aren't, and my only comment about that is that Health Watch is run by paid employees, and also each Health Watch has a board of directors, and that is something that's open for anybody to stand as a potential director of Health Watch locally, and then you put in your CV and your resume, and then you're voted on. So to a certain extent, we have the ability to dictate what Health Watch does, and I think we should remember that. Apart from that, I fully welcome the fact that you've had this whatever it is, a WebEx, and I think it's a really good idea. And in the Thames Valley, we're very conscious of the fact that patient participation groups do excellent work, and to that extent, we're running in March a patient participation networking event or whatever, particularly whatever terminology you want to use, but simply to get all the PPGs together. And I think they have a very, very important role to play within the NHS. So thanks very much for running this.
Oh, thank you, Carol, as well. It's good to hear you, because obviously we've met. We're just going to respond to the CQC question. Sorry, Sandra is going to respond to the confidentiality issue. I'm just going to mute you again, Carol. And then Peter to finish off with CQC, and then we'll round up.
Okay. Yeah, coming back on that confidentiality, you're absolutely right. It is key. We never would talk about an individual patient's circumstances, that they are all, any issues are raised as general issues. If an individual patient came to one of our members with a situation, the first response we would give is that would be to refer them back to the practice, and particularly probably the practice manager. So yes, confidentiality is absolutely paramount. However, having said that, the reason it may become an issue within a group is that if the group feels uncomfortable, if the members of the group feel uncomfortable about the inclusion of a young person and the responsibility that actually puts on the young person, which they may feel is unreasonable. So yes, I did. That's a very good point to raise, that patient confidentiality is always absolutely paramount. And
obviously depends on the chair doing that job with robustness. Peter, just to finish very quickly on any CQC involvement we've had?
Yeah, just mentioning CQC, I can only, and I'm going to get Sandra just to mention her own experience as well, but we've had a number of successful CQC inspections within Somerset. In my own practice, which was about, I think, 9 to 12 months ago, we had a very, very good CQC inspection, but as part of that inspection, I found myself having an interview on the telephone with the person who was leading it, which lasted for about half an hour, about how our actual PPG operated and the things that we did and how we interacted with the practice, etc. And what I found to be quite interesting in the thoroughness of that was that about 2 or 3 days later, having gone away to look at some of the things I've been speaking about, she came back to me to seek further clarification. And it was really quite pleasing from my perspective that when we read the CQC report, they were incredibly complimentary about the manner and the way in which the practice and the patient group had successfully integrated into a meaningful partnership.
Yes, in our case, we actually believe that we were one of the first practices in Somerset to have the new CQC inspection, which was being reviewed and started a few months ago, I believe. In our case, I would say that I found the process to be extremely efficient, the practice to be treated extremely courteously by those who came to do the inspection. The program was set up and kept to very well. In my case, the patient group was asked to send some representatives to sit for a period of about half an hour with one of the inspectors to exchange views and answer questions put to us specifically, and to advise as Peter said, on some of the activities and how the practice works with us and is involved with us. So as an experience, I found it extremely professionally carried out and well carried out. We are still waiting for the report, so I can't comment on the feedback yet, but so far so good.
Okay, thank you, Sandra. I'm just going to make one sentence ending to that CQC conversation before handing back to Peter, who will hand back to me to finish our session. I was yesterday talking to a CQC inspector, and they said it was a matter of policy for them, certainly as an inspector, to always go to a PPG when they're visiting a GP practice. And she actually said, I will go to 2 people in the PPG just in case it's a bit cosy hearing one person's view. So yes, so they went, in Sandra's case, they went to 4. Peter, do you want to quickly round up finishing of your seminar? And
I just think it's important just to, we'd have to have a word with a few people about what others think of the network, and I promise that this is being written by them and not by us. So you've got some comments there from Matthew Dolman, who's the chair of the CCG, David Slack, who's the managing director, and Janet Lowe, who's one of our practice managers. And just before finally going on, I did mention earlier there are some other things that we said we will attach to the presentation, which will be on the web. Purely to try to be helpful. If you want to ignore them, please do so, but equally if you find them helpful, don't be afraid to use them. We're showing you a sample agenda of a PPG, and we may even put a couple in there for you. When I say of the PPG, I mean of the network. We'll also let you see our agreed constitution, which came out of our working group, and there's also a copy of the virtual group guidance that Sandra was kind enough to facilitate, which has gone out to practices. So there are 3 documents there that you can use if you so wish. Because as I said at the outset, it really is quite important that we can learn from each other, that we're not always reinventing the wheel. And in relation to that, and finally, you've got some contacts there of myself, Sandra, Christine and Martin. If there are issues that come out of today, please do not hesitate to drop us an email and let us know. And one of us will certainly get back to you as quickly as we can. So as it says at the bottom, thank you for watching, listening and participating.
Thank you, Peter. And it only remains for me to also say thank you and to remind you or tell you of the ways, in fact, we can build on this conversation today. So Peter's already mentioned some of them. We've got a discussion forum in the Patient Voice South website, and there's already a discussion started, 2 people. So please join in that. Do feel free to tweet. Our knowledge bank, which is on the Patient Voice South website, we're going to put the information that Peter's just mentioned coming locally from Somerset, anything that you send us and are prepared to share. So we're going to have a separate section where you'll be able to search on PPG. So information, resources you're prepared to share. That would be great. And shortly, I will be sending out some of those resources, but also a short questionnaire. But unless you tell me otherwise by email, I will circulate that to everybody who's been on the seminar today, so you have each other's email addresses. Let me know if you don't wish that to happen. And you can continue the discussion or pick up on any people that you've encountered during our seminars today. So thank you again to all of you. Apologies that we didn't deal with all the questions. I suppose that's a bonus really, in that then means we need to communicate outside of the seminar. And thank you for joining us. Goodbye.